This is the one that takes us and brings us from here.
Me? Yeah. We start at 12:15, so I want to give everyone enough opportunity to get in class in the last, I don't know, yeah, I'll call it 23 seconds. It's, you know, it's my thing. I really, really, really try to start on time and try to end on time. Because I know that time is our one true non-renewable commodity in life. You can't make it, you can't destroy it. You can sure waste it. I'm sorry? I typically don't watch a lot of Justin Timberlake. Okay. Interesting. All right, good afternoon, everyone. All right, so let's go ahead and get rolling. So what we're going to start today, like I mentioned in the YouTube videos that I posted last week, we're going to roll right into the pelvis. Okay, the pelvis is going to be the last content that we cover up until the midterm examination, which is a week from today. Okay, so happy Valentine's Day. We're going to have a midterm. Because I know that this is not an intentional dad joke, but it's going to turn into a dad joke. You guys love taking midterms. Taking midterms. That's why we're doing it on Valentine's Day. Really? Okay. That's okay. So when we start talking about the pelvis, okay, what we're going to have to understand is that, number one, we're going to start putting in a lot of moving parts, okay? This is where the class is going to get not necessarily more difficult, but just understand there's going to be a lot of moving parts, okay? So number one thing I want you to realize is that when my pelvis moves, and when I say the pelvis, what I'm going to refer to is both the os coxae. Okay, so I'm going to write that word down for you guys. So pelvis, in anatomical terms, is called os, which just means bone, and coxae, which is going to mean the pelvis. Okay? When I move my pelvis is going to move as one large unit. And that's going to be very important to remember, because when I start moving my pelvis, other things are going to move in reference to that. Okay, so I know you guys are taking biomechanics right now, and you guys are talking about reference frames, right? So this is a really good example of a reference frame. So let's think about it. When I stand, or when I sit, or when I lay supine, I can rock my pelvis anteriorly, and I can rock it posteriorly. All right, pretty simple. When I rock my pelvis anteriorly, what happens to my lumbar spine? Does it flex or does it extend? It extends, right? When I rock my pelvis posteriorly, does my lumbar spine flex or extend? It flexes, right? And you guys probably, those who worked as techs or observed PT before getting in the program, you may have seen a therapist or two or 15 million do some pelvic tilts with patients, right? They're doing these pelvic tilts all the time, not necessarily because they want to quote, exercise the pelvis, right? Because I just said the pelvis is a big unit. It's a big solid thing, but they're trying to exercise one part of the body, move a one part of the body in order to enact change on another part of the body, okay? Now, here's the other thing we need to start thinking about. This, again, is where reference frame comes in. When I move my pelvis anteriorly, so I do an anterior tilt. I'll get over here so almost everyone can see. So when I do an anterior tilt, we just said that it's going to extend my lumbar spine. What does it do to, quote, my hip joint? Flexes it, right? Even though I'm not moving my femurs at all, am I? That's really important to remember. So I can enact hip flexion without moving my femurs, right? Because I'm anteriorly tilting my pelvis. Therefore, my hips are, quote, in flexion. Same thing. If I do a posterior pelvic tilt, then I am extending my hip. My hip is moving into extension, despite the fact that my femur is not moving at all. So very important to remember, because as we start moving through the human body, and we'll get into this even more when we talk about the hips, you guys are going to start looking at the human body as not necessarily a stationary object, and we've done that a lot so far. We've talked about the human body as a stationary object, right? Here's my humerus, here's my radius, here's my tib, here's my fib, that sort of stuff. As you guys progress into this program, we're going to start adding in the element of movement. So one thing you guys are going to get primed for in this class is going to be biomechanics. And the other thing is going to be a class called gait and movement analysis next year. Because let's think about it. If I'm walking, how many different moving parts are happening? Darn near all of them, right? Darn near all of them. So think about this, and we'll get into this a little more when we get into the hip. When I take a step, and I'm now, you guys can see, I have 1 foot in front and 1 foot behind. What direction is my pelvis? Is it still pointing forward? Or is it pointing out to the side? Right, okay. So my pelvis has rotated to the left, has it not? Right? So now what I see is I have transverse plane motion happening in my pelvis. Okay? Now think back to what I just said about my hips. And now they're in a different position because my pelvis has changed position. Where's this hip? Little flexion. What else? External rotation. Okay. Where's this hip? Internal rotation and extension. Okay. Because now my hips are neutral. I'm moving my pelvis. This hip is now an external rotation. This hip is now an internal rotation. Okay? So I want you guys to understand that I don't necessarily just need to stick my leg up in the air and perform internal and external rotation. I can move my pelvis because my pelvis is a firm, solid object. And I can create all sorts of different motions because of this solid object moving at the chain parts above and the chain parts below. Yes?
So if you're rotating to the right, your left is
Can you say it one more time?
you're saying if you're rotating to the right, the left internally rotates, but the right externally rotates.
If I'm rotating to the right, because this is the easiest way to do it. I've seen this happen in the clinic, okay? Flashlights. I have patients do this, okay? Guys, your flashlights are going to be your ASISs, right? You guys know what ASIS stands for. Okay, sweet, we've got our flashlights. We're going to turn our flashlights to the right. Okay? Now look what happened here. Where's my left hip? Internal rotation. Where's my right hip? External rotation. Okay? I'm going to turn my pelvis, quote my flashlights, to the left. Well, where's my left hip? Internal rotation. Where's my right hip? External rotation. Okay? That's all I'll say. But literally, the little flashlight thing, it's fantastic. Because you'll have patients, especially someone getting more into the neuroanatomy, there's something called hemi-neglect, where they don't even know where one side of the body is. Like literally doing this and making sure they know that, hey, I have a right side of my pelvis is key for things like gait. Because literally, they'll just sit there and drag your leg behind them and not even know they're doing it. Okay, so you have to cue your patients in that sort of manner. All right, so first thing I'm going to cover is something called the true pelvis versus the false pelvis. Okay, and this is a term you're going to see in the textbook, so I want to dispel some myths here. Okay, so number one, get a thicker pen here. So if I'm going to look at this picture down here at the bottom, and I have essentially this being my left ilium, and this being my right ilium. This area down here is going to be called my pelvic outlet. And then what I'm going to see is something called a false pelvis. Okay, now the false pelvis essentially is going to be this line here. Okay, so you guys probably in tests and measures have learned that if you put your hands on top of the iliac crest, that's going to correspond with a certain lumbar level, like the L4, L5 interspace. Does that sound familiar? Okay, fantastic. So this is going to be the L4, L5 interspace. This is referred to as the false pelvis. And the reason it's referred to as the false pelvis is because that's not really where we're going to see a lot of our, quote, pelvic contents, okay? We're going to see our sigmoid colon, about L4, L3, 4, 5, depends on the person. We're not going to see our pelvic floor muscles, and we're not going to see our pelvic contents until we get a lot lower here. So if we draw in where, I'll draw it in a different color. If we draw in where I'm going to see my hip articulation, okay, so let's kind of imagine these little half moon circles being my hip articulation. These little half moon circles are something called the acetabulum. My hip then is going to be the articulation between the acetabulum and the femur. So the technical term for the hip is actually a layman's term. So the technical term for the hip, we're going to get into this a little more next week, is the femoral acetabular joint, which I think is actually a more accurate representation rather than saying hip. It's one of those things, again, says what it is what it says, right? We've already talked about a lot of these different joints so far, right? Remember, we have my scapulothoracic joint, right? And we have my glenohumeral joint. This is going to be another one. So when I refer to the femoral acetabular joint, that's going to be the articulation between the femur and the acetabulum. Understand that my acetabulum is going to be a portion or a section out of my pelvis. Okay, that's going to be really important to remember because we're going to see patients with something like femoral acetabular impingement syndrome, right? So that's where the femur and the acetabulum have come together, created a bunch of shear forces, and they started to shear off things like cartilage or synovial lining. So my femoral acetabular joint is going to be, quote, my hip joint, okay? The reason that's important in terms of true pelvis versus false pelvis is that right at the very top, the superior aspect, I'm trying to find a color here, that'll work. Right at that very superior aspect of where the acetabulums are, that's going to be really where my true pelvis is. So this is where I'm going to see my pelvic contents, down in my, quote, true pelvis. So this is where we're going to see a lot of my pelvic arteries, right? We're going to draw an entire picture of all the branches of the pelvic arteries. This is where I'm going to see things like my bladder, okay? Because what we're going to see is the floor of the pelvis. And for those of you who have a little bit of experience with like pelvic therapy, you're going to hear a lot of pelvic floor, right? So what is the pelvic floor? Please nobody answer the floor of the pelvis. That's the answer my son gives me, right? So really what the pelvic floor is a series of muscles that literally provide a sling, okay? They provide almost like a little hammock. They almost look like a little hammock for contents like my bladder, things like my uterus, things of that nature. That pelvic floor is going to have a series of holes in it, right? Because I need things like my rectum to excrete or my urethra to excrete. Also, reproductive organs need a way to get externally to internally. So that's the other thing that really makes the pelvic floor kind of unique is it's not a solid wall of muscle. And we've seen solid muscles throughout other portions of the human body, right? My forearm didn't have a ton of holes coming through it, right? Peroneal arteries a little bit, but not really anything significant. Now I have a series of muscles that have pre-designed holes going through them, which is exactly where we're going to see a lot of pelvic floor dysfunction, is going to be where those muscles interface with those different holes. Okay, any questions about true pelvis versus false pelvis?
Can you repeat what you said pelvic floor is?
So the pelvic floor is essentially a sling of muscle. And we're going to go over each of those muscles individually. Okay? They have names that are about this long, maybe this long. All right, any other questions? Yes, sir.
Does the true pelvis equate to circumference? What were the different first?
So true pelvis is actually going to be closer to our sacrum. Okay, so we're actually going to see like S1, S2, where my true pelvis is. Okay, because remember, Once I get below L5 here, and I think that's a great point to make. Once I get below L5, then what I have is S1, S2, S3, S4, and then I have my coccyx. Coccygeal 1, coccygeal 2, and it just kind of tapers down from there. So Dr. Justice has a great representation there in the back of the classroom. So you guys see where his hands are.
Right?
That's exactly right. So the pelvis. So the true pelvis is going to be that lower indentation, right? That's going to be that big ring. So we're actually going to call that the pelvic ring. And inside that pelvic ring, that's where my pelvic floor muscles are going to sit. That's where my bladder is going to sit. That's where the uterus is going to sit. All that great stuff. Okay? Yeah, it is. Yeah, good point. So at rest, there is an anterior tilt to the pelvis. Okay? Not a ton of anterior tilt, but there's a tiny bit of anterior tilt. All right, any other questions on true pelvis versus false pelvis? Okay. All right, I want to make sure you guys get these concepts down. So, I'm sorry? Oh, okay. I want to make sure you guys get these concepts down because literally, like, the next 5-6 weeks is all going to jump on these type of concepts. So if we don't understand what's happening at the pelvis, then things are not going to make sense later on. All right, so next thing is what exactly is my pelvis made up of? Yes, please.
You know, when we consider patients falling, you know, that is a big, especially in an aging population, that's a very big concern, fracturing the pelvis.
Yep.
Which one of those, as a general rule, is going to, may seem kind of self-explanatory, but which one's going to be a bigger immediate blood loss that we need to be concerned of if you're fracturing the true or pelvic, you know?
So a true pelvic fracture is going to be much more life-threatening than a false pelvis fracture. Now, typically, and this is going to get into next year's stuff, so forgive me on this one. So with the pelvic ring, okay, we already talked about C1 fractures in here a little bit, right? Remember how C1's a ring? Okay, if I take a ring and I explode the ring out, I'm typically not going to see one fracture place. I'm typically going to see two. Okay, because if I'm taking a force straight down through the middle, and that force is typically that person's body weight, what will happen is the ring will explode out. Now, this is where the it depends stuff comes in, because it depends on a ton of different things. Everything from mechanism of injury, like how that person fell, did they fall down the stairs versus did they get kicked off a horse, all that stuff, all the way to the integrity of the actual bone. Did they have something like leg calves Pur's disease, or did they have something like osteoporosis, right? Because osteoporosis is not necessarily uniform. There can be certain weak points in the body, right? Now, as far as life-threatening structures go, that will be very dependent on what happens next. So I'll give you an example. If I have a pelvic ring fracture, and I have a sacral fracture, and a fragment of the sacral fracture slices through the common iliac artery, that will be life-threatening. So there's going to be a chain of events. So what we're going to learn is femoral artery is actually going to come out under the inguinal canal, and that's actually going to be a little better protected than something like internal iliac.
And that's where I'm thinking, like, even if we have a non-displaced fracture, for instance, you know, which one is, like, when you have a femoral fracture, you have a lot of significant blood loss that can happen very quickly.
Yes.
But assuming that, like, the common iliac and the femoral are intact, just based on the osteology and the size, which one, that was kind of where my thoughts were as far as the blood flow and the perfusion that occurs in that bone tissue.
Yeah. So yeah, it's unfortunately, yeah, and I always say in the clinic, I don't get too hung up on how you got here, because you show me 100 rotator cuff surgeries, I'll show you 100 different rotator cuff surgeries. I mean, it's the same thing with pelvic fractures. You show me 100 of them, I'll show you 100 different ones. Yeah, it is. There's so many variables involved that I don't even mess with it. Quite honest with you. I more go towards what are your functional limitations. So, but good question, good discussion. All right, so first thing we're going to learn here, you guys probably already read this. I'm basically going to have 4 different bones that's going to make up my pelvis. Okay, number 1 is I'm going to have something called my ilium. Ilium is going to be, for lack of a better term, my Ohioese is going to come out here. Well, this is a big honking bone. And it's going to kind of come up and around. There's going to be a big notch in it. So this is going to be my ilium. Second big bone I'm going to have here is going to be something called my ischium. Now my ischium is going to have a tiny little prominence to it, and then it's going to have a large tuberosity, which is going to be called the ischial tuberosity. Okay, so down here is going to be my ischium. And you guys probably have already kind of learned from test and measures, those sit bones are technically my ischial tuberosities. That's going to be important to remember much later on, because what we're going to see is all of my hamstring muscles and their proximal attachments is going to be right on that ischial tuberosity. So again, start thinking about it. Go back to the fall person. Let's say they fall on their rear end. It's possible that person could have a hamstring rupture falling on the rear end. Why? Because that's where the hamstrings proximally attach. Okay, so important to know where that ischial tuberosity is. The other piece I'm going to have here, which is going to form this kind of ox coxae. Let me get a good color here, good purple. This is going to be my pubis. So pubis is going to be that bone that's kind of right in the front. When both of my pubis bones come together, what we're going to see, and we kind of drew this in when we talked about the inguinal canal, I'm going to have one pubis comes from one side, right side, one pubis comes from the other side, and they're going to come together in symphony. Okay, that's what symphony means, is coming together. So that's going to be called my pubic symphysis. So literally what we see I'm going to see one pubis bone on one side, one pubis bone on the other side, and right here in the middle is going to be my pubic symphysis. Now, what's really important to remember about the pubic symphysis is that the pubic symphysis is not bone. In fact, the pubic symphysis is all cartilage. So what I want you to think about, again, this is where a lot of moving parts are going to start coming together. I'm going to give you an example. Okay, I had this patient, 14-year-old patient, it's about 12 years ago. So essentially she's now your age, which is a little daunting to think about. So she got really sick, recovered, wanted to go back play high school softball. First day of softball training, and when I mean sick, like she was in the hospital for like 6 months, in a hospital bed for about 6 months. So right off the gate, Is she in great condition or is she deconditioned? She's deconditioned. First day of softball conditioning, guess what they have her doing? We're going to do single leg hops, guys. So she's sitting there, single leg hopping. All of a sudden, she thought she got shot because what she heard was her pubic symphysis rupturing. So then here's what happened, okay? Let's think about this. The pubic symphysis keeps both of those pubis bones together. So here's what happened. And this is where biomechanics comes in. She's hopping on one leg. The force from the ground shoved one side of the ox coxae, one side of the pelvis, superiorly and posteriorly. The other side stayed where it's supposed to stay. Okay? Number one, super duper painful. Number two, really easy to fix. So what I had to do was we did something called a muscle energy technique, and we started working that side of the pelvis back to where it's supposed to go. And then we just did a bunch of exercises to stabilize that position. But that was the mechanism of injury, was literally a superior and posterior displacement of one side of the pubic bone. Okay? The reason being is because that pubic symphysis was not able to withstand the shear forces, right? Because if I have one part that's not moving, it's stable, and another side that is moving, that's going to create a shear, is it not? Get back to like tissue mechanics and biomechanics, right? That's going to create a shear. If the integrity of that structure is not strong enough to withstand that force, I'm going to have a rupture. Make sense? That's kind of how it happens. On the lateral side of my ischium and my ilium and my pubis, I'm going to see the structure that we kind of talked about, and that's going to be my acetabulum. Acetabulum is going to be literally where that femur is going to articulate with the pelvis. Other pieces and parts that I'm going to see here, at the very top, this one's pretty easy. This is going to be my iliac crest. And then I'm going to have two rather large and really super important notches. I'm going to have something called the greater sciatic notch. And then inferior to that, I'm going to have something called the lesser sciatic notch. I'm also going to have something, we already talked about an ischial tuberosity. This little thing here, this little protuberance, is going to be called my ischial spine. Now, the reason I want to focus in on those is because, like I said, the pelvis is one solid, really honking object. What we have to ask ourselves is what provides all that stability. What's going to provide all of that stability, and we're going to get into this here in just a little bit, is going to be a very dense network of ligaments. I'm talking they are super strong and they are super dense. In fact, I can't wait for you guys to get into that part in cadaver lab, because I kid you not, and Dr. Justice can probably verify this, you can take a couple of the legs and try to pull those things apart, and it ain't happening. In fact, another story. My next door neighbor decided to catapult himself off an ATV here about a year ago. I don't think it was intentional, but it is what it is. He did not dislocate his pelvis. He did fracture his sacrum, though. That's how strong a lot of these ligaments are. Even though he decided to catapult himself, he claims about 15 feet, which means it's probably about 8 feet. Right? He's the guy, you know, the fish turns into this big, it grows this big. That's okay. But anyway, he did not dislocate any of those ligaments. He did not rupture any of those ligaments. He did fracture his sacrum. Okay, that's how dense and how strong this series of ligaments is. Now, the reason I want to bring up a lot of these little protuberances and landmarks is because what we're going to see is we're going to have a lot of different ligaments that are going to end up creating a lot of spaces and a lot of different holes for different structures to pass through that are all going to be named based on what structures they attach to each other. So what we're going to see, and we're going to get into this here in just a little bit, is we're going to have something called the sacrotuberous ligament. Okay, and that's going to attach my sacrum down to my ischial tuberosity. That's why it's called sacrotuberous. I'm also going to have something called my sacrospinous ligament, which is going to attach my sacrum down to my ischial spine. So I want you guys to get a really good sense of where all this stuff is, because when you look at a picture like what's in Gray's and Netters, it looks like a bunch of cobwebs in there. It's like there's stuff going all over the place. So the fourth bone that we're going to encounter here, is everybody good with this picture? Is anyone not good with this picture? Okay. The fourth bone we're going to encounter here is going to be my sacrum. Okay, so bone number 4 is going to be my sacrum. Now, my sacrum is literally going to be just the continuation of my spine, but it is going to be all solid. Okay? So my sacrum is going to be this large object here. And then I'm going to have vertebrae that are going to be stacked on top of it. Okay, so to give you a reference point, here's L5. I'm going to draw little holes in here, little circles. And these are going to be called, as a group, we already kind of know the word for hole, right? Foramen. The plural or multiple of foramen is foramina. So as a group, those are called my sacral foramina. What we're going to see is I'm going to have a whole nother network of nerves, aka another plexus, that's going to come out of those sacral foramina. And that's going to be my lumbosacral plexus. That's going to provide a large amount of the innervation down the posterior thigh and into the pelvis. So, for example, you guys might be familiar with the sciatic nerve, right? Everyone sound kind of familiar? The sciatic nerve is going to be made from my lumbosacral plexus. Okay, to give you guys a little bit of reference point. My sacrum is going to have a couple wings to it. Okay, so this is going to be a wing, and this thing is going to be a wing. The Greek word for wing is ala. That equals wing, okay? So literally when the original anatomists were looking at the sacrum, they're like, oh, look, that has a couple wings to it. Let's call them wings. So that's exactly what they did. This entire section here is going to be the body of the sacrum. Now my sacrum, and this is kind of looking, I'll label this. This is an anterior view of the sacrum. If I flip my sacrum around to the posterior side, what I'm going to see is I'm going to see a lot more landmarks. Landmarks that you guys may have already kind of covered in test and measures. Everybody good with this picture? Anybody not good with the picture? It's either ala of the sacrum or sacroiliac. Either way. Either way. I think Netters literally calls it sacroiliac, and I think Grace calls it ala of the sacrum. It's healthcare. It's not standard, unfortunately. All right. So from a posterior side, it's going to look very, very similar to the anterior side. So those holes are just going to represent the foramina again. Okay, so now this is my posterior side. But what I'm going to see here are going to be a couple key landmarks. What I'm drawing in blue here is going to be my posterior superior iliac spine, which is actually going to be part of the ilium. Okay, like we talked about, we have ASISs, therefore we're going to have PSISs too. Okay, so on my posterior side, what I'm going to see, and you guys probably can view this on each other. If you ever look at somebody and you see those two little dimples, those two little dimples are right next to the posterior superior iliac spine. So it goes by the common abbreviation PSIS. Now, you guys know this because you guys are pretty good. If I have a superior one, it means I got to get an inferior one too, right? So way down here, and again, this is going to be another part of the ilium, is going to be the posterior inferior iliac spine. Also goes by PIIS. What I'm also going to see here, and I'm going to draw this in, this is going to be kind of a, for lack of a better term, an exploded view. Okay, if this area over here is my ilium, and this is my sacrum, the joint that they're going to make is going to be my sacroiliac joint. This commonly in PT literature and PT clinical practice goes by SI. So you will see very commonly that's called the SI joint, or a lot of people will call it SIJ. So when they're referring to SIJ, and you'll hear that in clinical practice a lot, and that's why I want to bring it up. SIJ is simply the sacroiliac joint. The sacroiliac joint is simply the interface or the articulation between the sacrum and the ilium. Okay? Now, what we're going to see is that, and this is where this kind of very, very dense network of ligaments comes in. What I'm actually going to see is I'm going to see two very wide, very thick, very dense ligaments. I'm going to see one that's going to come off the posterior aspect of the sacrum and attach into the ilium. And it literally kind of comes out to like this big cone shape and attaches into the ilium this way. I'm running out of colors. This guy here is going to be the posterior sacroiliac ligament.
Can you say one more time where
It comes off the posterior aspect of the sacrum and attaches to the posterior aspect of the ilium. So that's my posterior sacroiliac ligament. Okay, it kind of says what it is what it says. This is how stable this joint is. Now, I'm going to be very, very honest with you. There is a huge debate in physical therapy practice on whether or not this joint actually moves or not. There are some people that believe it does not move. There are some people who believe that it does move. And the problem is there's an equal number of research articles on both sides. In the average person, this joint moves around 2.5 to 5 millimeters. Right? That's it, that. And some people, it moves more. And some people, it moves less. But the average is about 2.5 to 5 millimeters worth of movement. Reason is because I have two really super duper dense ligaments happening here. I got the posterior sacroiliac ligament, and then I'm also going to have coming off the anterior aspect of the sacrum attaching into the ilium. I have an anterior sacroiliac ligament as well. Obviously not going to draw that one in here because we're looking at the posterior side.
when it comes to function, just keep the sacrum and the iliac good?
Yep. So that's what a ligament does, right? Think back to like last semester. Well, what's the job of a ligament? A ligament attaches bone to bone, and what the job of a ligament is to not allow those bones to move more than what they're supposed to, right? Okay, so we've seen some ligaments that are more stretchy, like we're going to get into ACL and PCL and things like that. Those allow a little bit of motion because they're supposed to. When it comes to the SI joint or SIJ, anterior sacroiliac ligament, posterior sacroiliac ligament are very dense, very, very thick, very, very wide. They're going to hold those joints really, really well together. The other big ligament I'm going to see back here is I'm going to see something coming off the transverse process L5, and it's going to attach directly into my ilium as well. And this is going to be called my iliolumbar ligament. So you guys probably saw from your reading that muscles like quadratus lumborum have a little bit of attachment into the iliolumbar ligament. And this is kind of how it happens. So quadratus lumborum, again, it's one of those muscles. It's not necessarily named for where it is, kinda. It's more named for what it looks like, right? So what's a quadrilateral in math? It's a four-sided object. So quadratus just means four-sided muscle in the lumbar region. So quadratus lumborum. It attaches into inferior aspect of T12 all the way down the lumbar spine, attaches into the iliolumbar ligament on its way to attaching to the iliac crest. Okay? So that's what quadratus lumborum is. We'll draw that one in a little later. Everybody good so far? Okay. Does anybody need to take a break? Okay, I got a hand. All right, okay, let's take 5 minutes.
Is there any chance that you were going to have some practical practice stuff during class before we have our exam next week? Like a question or two?
I can throw one in Wednesday.
If you don't mind, it'd be fantastic.
Yeah, sure, I can do that.
Kind of get back into the.
Yeah, I can do that. Yeah. One more time for this little bit.
It definitely can be, not as much as other things, if that makes sense. Typically the PGS, they're also doing what type of PGS it is, so they're really quite high. Yes. There's like, you don't want to have type 3, because type 3 is where you actually get elasticity of your vascular walls, so your arteries don't snap out like they should. That's proper, right? It's going to affect the good thing about this particular ligament is that it is so dense and so thick, you might not see all the clinical ramifications of it, right? So you're still more likely to dislocate your shoulder than you are your side joint, but just realize that because you have that diagnosis, you both are more likely than the average person. Makes sense? No worries.
Again.
So, I mean, these are one of our tribes. One has some. One's got dirt, one's got brown. Yeah.
Guys, everyone back? Anyone not here, raise your hand. Gotcha. All right, so getting into some of our lumbosacral joints, some of the different ligaments that we're going to see surrounding this unit, and getting into a little bit of the associated musculature. Now, I'm going to warn you, this is kind of where the course starts smushing a lot of concepts together, right? Because we can't really talk about muscles like psoas major or iliacus without discussing what their function is, and their function is hip flexion, right? So this is where things kind of get smushed together a little bit, and I will apologize for that from the get-go. All right, so first thing we're going to do is we're actually going to draw out what's going to be this picture down here at the bottom. These are a little the easier ligaments. All right, so what we're going to do is we're going to draw out a big ilium. Okay, so there's my ilium. We're going to draw out a big notch out of it. Okay, so this area here, I'll color it in. This is going to be my greater sciatic notch. This guy down here is going to be my ischial tuberosity. And then I'm also going to have a little outcropping, which is going to be my ischial spine. So obviously this is going to be one half of my pelvis. I'm also going to draw in one half of the sacrum. So this guy here is my sacrum. Bless you. So on the posterior aspect, I'm going to see two pretty darn large ligaments here, okay? The first one is going to actually come off the anterior portion of the sacrum, and it's going to attach in here to the iliac spine. This guy here is going to be called my sacrospinous ligament. Now, ligaments are great because the vast majority of them tell us exactly what they attach. There's going to be some exceptions, especially when we get down to the knee joint, that we're going to have a couple ligaments that really don't tell us much of anything, but we're very familiar with them because they're things like your anterior cruciate ligament, your posterior cruciate ligament, aka ACL, PCL. So my sacrospinous ligament is going to attach in, it's going to attach from the anterior portion of my sacrum to my ischial spine. The other larger ligament I'm going to see here is actually going to have three large sections and it's going to attach my sacrum to my ischial tuberosity. This guy, I'll draw a different color so it sticks out a little bit. This guy here is going to be my sacrotuberous ligament. Now, as you can see, the sacrospinous ligament and the sacrotuberous ligament are very large, and what they're going to do is they're going to basically give another point of stability to this entire unit. Remember how I said my pelvis is a very, very stable object. Here are two more ligaments that are going to add to that stability. The other thing that my sacrotuberous ligament and my sacrospinous ligament are going to do is they're actually going to provide two really key landmarks for my pelvis, okay? Because what we're going to see, is everybody good with this picture? Everybody, anybody not good with the picture? Not good? Okay. That's fine. If anyone's not good with the picture, that's fine. I will wait. I, be quite honest with you, I don't think it's that necessary. No, it's a sacrotuberous ligament. Anterior, middle, inferior. Yeah, that's about it. But no, it's a sacrotuberous ligament. Good question. We good? You sure? Okay. The first answer wasn't that confident. Are you done or are you not? Are you not done? Okay, you have a question. Okay, what's up?
Picture we just done, where it was the 4 bugs.
Yep.
On this side is where you have the like prayer strap. And so where does kind of everything correlate, if that makes sense? Like if we were to add a sacrum to this picture, where does the sacrum sit?
I'm going to draw it in the next picture.
Okay.
No worries. Okay, so what we're going to do is we're going to kind of move on to a different picture. We're going to move on to the very top picture. It should make more sense with that. Okay. Yeah, what's up? That was the posterior aspect. Yeah, we're going to draw anterior next. So anterior aspect's coming up, okay? So what we're going to do is we're going to move on to this picture up top here. So here's what we got, okay? Got my pelvis. The pelvis is going to have a ring to it with a little bump. That's going to be my ischial spine. And then there's essentially going to be my sacrum. This is the anterior view. So like I said earlier, my sacrospinous ligament is going to come off of the anterior aspect of the sacrum, and it's going to attach in to the ischial spine. Okay, so that's my sacrospinous ligament. Sacrospinous ligament is going to have much more of a transverse plane orientation to it. I know I obviously didn't draw the picture to scale, but it's going to have a much more transverse orientation to it. My sacrotuberous ligament is going to have much more of a vertical orientation to it. So in fact, you know what I want to do? Let's do this. Hold on. Hold on. Really? I'm going to make it easier. So what you guys can probably see already, okay, so my sacrospinous ligament is going to attach in from my sacrum to my ischial spine. Sacrotuberous ligament is going to attach sacrum down to ischial tuberosity. Yes.
More anterior.
It's more posterior, actually. Yeah, more posterior. So I tell you what, let's do this. Is that better? Okay. That's not perfect. It's better, though. Come on, it's my drawing. It's never perfect. Give credit where credit is due. That is not winning any awards.
You accepted some horrible spelling on our lab exams last year from my part, so I.
That's a fair point. What I've learned is if I close one eye and look sideways, I can kind of make out what it's supposed to be. But it's a lot better, and Dr. Justice will admit to this, than when we used to have you guys handwrite it in. Oh, man. Ooh, that was interesting. So here's what we have. We have two areas here, right? We have two areas of space, or, as I like to call them, two holes. We already know what the word for hole is in anatomy. So what we're going to see here is we're going to have the greater sciatic foramen. Whoop, there's a T on foramen. There we go, that's better. And then obviously we're going to have a lesser sciatic foramen. So when you guys see those terms in the literature, that's essentially what we're talking about here, okay? So greater sciatic foramen is going to be the negative space, aka the hole, superior to the ischial spine. Okay, so we already kind of talked about these anatomic areas, right? Remember, I'm going to bring back a memory here. Triangular space, quadrangular space, triceps hiatus, remember all that stuff? And remember we talked about location, borders, all that stuff, right? So think about what my borders are going to be here. My borders are going to be obviously the inside of the pelvic ring, sacrospinous ligament, tiny bit of sacrotuberous ligament. My greater sciatic notch is going to be superior to the sacrospinous ligament. Lesser sciatic foramen is going to be inferior to the sacrospinous ligament. Okay? So that's going to become very important when we start talking about contents that are going to be exiting at each of those.
Is this viewed from the exterior side or posterior?
I'm not going to.
Anterior.
Yep, anterior. Yep. I know, with these drawings, it's kind of hard to tell what it is, let alone what side we're looking at, right? No problem. No problem at all. That's right. I'm trying to like label these as we go. Literally simply because of that. All right. Any questions on sacrospinous ligament, sacrotuberous ligament? Everybody good with that concept? Okay, so when you guys look at that in the readings, in the literature, and especially identifying stuff like this for like lab exams, a big portion is understanding where those ligaments are, because what's going to happen is you're going to see a cadaver prone with gluteus maximus removed and a tag sitting in a ligament. And you're going to have to know whether or not that's sacrotuberous or something else. Okay? So that's kind of, I want you guys to understand where all this stuff is to help you guys out in things like lab exams. All right, so obviously we're going to encounter some muscles here. So everyone go with this picture. Everyone not go with this picture. All right, sweet. Okay, so again, we're going to look at the anterior view here. All right, so a little bit of orientation here. All right, so we're looking at an anterior view of lower lumbar or lumbar spine, sacrum, ilium. Big muscle we're going to encounter here is going to be quadratus lumborum. Okay, so quadratus lumborum is going to come off of a little bit of the 12th rib, transverse processes of T12, L1, all the way down here. And it's going to then come out to the iliac crest, iliolumbar ligament, and it forms this nice square-shaped muscle. So this is going to be quadratus lumborum. Ooh, that was really bad. I can't draw right sideways at all. Now, quadratus lumborum is going to be very key for a lot of different motions that I have. What quadratus lumborum is going to do is it's either going to side bend, right? So laterally flex my lumbar spine. The other big thing it does, and this is where we as physical therapists need to be really, really key on this, is it's going to do something called hip hiking, okay? Or it's going to displace or move one half of my pelvis in a superior direction, AKA it's going to do this number, okay? So that's my quadratus lumborum. We'll do it over here so you guys can see. This is my quadratus lumborum activated, okay? Now, here's what I want you to start thinking about, okay? And this is where a lot of moving parts are going to come together. We have a patient. They are coming to you for back pain after a total knee replacement. Here's where you have to understand how the human body works together. Let's say they had a total knee replacement, right? They did not achieve full knee flexion or adequate knee flexion to walk correctly, right? Because we all can agree that I need to bend my knee in order to clear my toes, right? If I don't bend my knee when I walk, what's going to happen? I'm going to drag my toes. What else am I at risk for? Tripping and falling and making a dumb TikTok video, right? And we don't want to do that. So, what people will unconsciously, subconsciously do is say, oh, I don't like that. And my knee is not bending adequately. I'm going to substitute something else. I'm going to use a different body part to achieve the same effect or a similar effect. So very common substitution, or in the clinic you'll hear this called a compensation, is I'm going to hike my hip in order to clear my toes. So who's seeing the clinic? Somebody that comes in and they're walking like this, okay? They're doing this number. They're not bending their knee. I'm working quadratus lumborum the entire time here. Do you think that'll increase back pain? Heck yeah, it actually has already increased in me from doing 15 reps of that. You as a physical therapist will need to understand that yes, the primary diagnosis or the primary reason the person's coming in is low back pain due to quadratus lumborum dysfunction or overactivity, whatever word you want to use. But then you need to dig deeper and figure out why it's happening. Why is that person using quadratus lumborum so much? So this is where you have to take a very, very broad, wide lens and figure out what that patient's doing. The next big muscle we're going to encounter here is going to be psoas major. Psoas major is going to come off of basically the transverse processes of L1 to L5. And what we're going to see is our psoas major is going to combine with another muscle that's going to originate off of the iliac crest, or the iliac fossa to be more specific. So we're also going to have this other muscle that comes off of the iliac fossa. And this is going to be my iliacus. There's another muscle that you're going to read about in Gray's called psoas minor. Psoas minor is not going to be present in everybody. And in fact, you can live a very, very fruitful life without a psoas minor. Yes?
So do you think that the psoas major iliacus is more posterior or lumbar stabilizer? There's a lot of PT really stabilized more so.
So here's what I will ask you in return. What does psoas major do? Okay, what does iliacus do? Okay. Can you say it louder for me? So then let me ask you this. Okay, and I think this is a great point. All right, so if I have, quote, tight hip flexors, okay, what two clinical presentations may I see? Okay, I'm going to write them down. This is good. Okay, so tight hip flexors. Okay, I could see an anterior pelvic tilt. Yeah, it works. What else? Low back pain is going to be a symptom. What signs? Signs are outward things that I'm going to find. Increased lordosis. Ooh, that sounds fun. Why? Because you have an anterior tilt. Okay, why else? I didn't hear your answer over here. Why? Okay. Okay, so you're hitting right around the answer. Okay. Psoas major, where does it originate from? Anterior aspects of the transverse processes of L1 down to L5. Okay, this is why we get so detailed with a lot of these attachments, even though I understand it's a huge pain in the butt to remember. Okay, I understand that. But this is why. Because if my psoas major originated off the posterior aspect, I would see a whole different presentation versus the anterior aspect. Okay? Because let's think about it. Okay, if I have psoas major, and I'll come over so you guys can see it as well. If I have psoas major originating off of the anterior aspect of the transverse processes of L1 to L5, and it inserts into the lesser trochanter of the femur, that's where it inserts. If that muscle gets short, two things can happen. One is I can bring my femurs up to my lumbar spine, right? I'm shortening my quote hip flexors here. Agreed? Or, as an added bonus, because I like to stand up straight and see things, I can bring my lumbar spine down to my femurs. Okay, so what did I just do there? So you guys can see over here. Okay, so I'm either going to bring my femurs up to my lumbar spine, or I'm going to bring my lumbar spine down to my femurs. Okay, did I increase my lordosis or decrease it? I increased it, right? So that's how it happens. Okay, so in terms of the psoas major being a lumbar stabilizer, it can be if you are co-contracting with other musculature. Okay? Now, and this is where stabilization, I will say, gets really, really sticky. I can't contract one muscle and create stabilization. I need to have a concert of muscles acting together to create stabilization. Does that make sense? Okay? So is it a hip flexor? Absolutely. Is it a lumbar stabilizer? Absolutely, with help of all of its other friends, right? It's part of the Brady Bunch. It needs the entire family or it's nothing, okay? I understand it's a really old reference. What's that? Right, in symphony. In symphony, I like that term. Okay, so iliacus, like we said, coming off iliac fossa, it's going to join forces with psoas major, and it's going to form this muscle that's not really a muscle, we call it a muscle, iliopsoas. Right, so when you see that term, you'll see that in the OATIS textbook. You're going to see that next year when you guys take MSK. Iliopsoas is simply the combination and the blending of fibers from psoas major and iliacus. Okay? All right. Okay, so psoas major is, it blends fibers with iliacus to combine into iliopsoas. Both of those muscles are going to then insert onto the lesser trochanter of the femur. What we're going to learn when we start getting into the femur, obviously you guys have probably already covered the greater trochanter because it's a fantastic landmark for things. If we have a greater trochanter, obviously we're going to have a lesser trochanter too. The lesser trochanter is going to be located on the medial aspect of the femur. Don't go try to palpate it. It's going to be a booger to try to palpate and kind of uncomfortable. Yes?
Oh, well, I guess I can ask this. You said it's not technically muscle, right?
It's not technically a full muscle. It's a blending of fibers. Okay? So that's why if you look in Gray's, you don't see iliopsoas listed. You see psoas major, you see psoas minor, you see iliacus. You don't see iliopsoas. Later on, down the chain, when you have this blending of fibers, it's commonly called iliopsoas.
And they have unique neural innervations.
They do have unique neural innervations, but they overlap a ton. So, for example, psoas major's innervations are the ventral rami of L1, 2, 3, and 4. Iliacus is L2, 3, and 4, which is commonly called the femoral nerve. So, psoas major gets a little extra help from L1. So think back to this, and I think it's a good point. How did you guys test the L1 myotome? Was it hip flexion? Okay. How did you guys test the L2 myotome? Hip flexion, right? How did you guys test the L3 myotome? Knee extension. Okay. How did you guys test the L4 myotome? Dorsiflexion, right? How did you guys test the L5 myotome? Wasn't it great toe? Okay. Notice how we're moving down the chain. Same sort of pattern is going to happen here. Okay. Higher the muscle, higher the innervation. Lower the muscle, lower the innervation. Okay. It makes no sense for L1 to throw a branch to iliacus. It's not efficient. It does make a lot of sense for L1 to throw a branch to psoas major though, because it's right there. All right, let's go ahead and cut it here for today. And then Wednesday, we're going to have more anatomy fun. Thanks.
No, I'm just not.
Oh, what's up?